Jadi, nak saya start dulu ke awak dulu?
Awak dulu lah.
Okay.
Ke Dahiyah rasa macam ni? Dahiyah dah tak sabar dah.
Saya ikut doktor saya.
Saya tak tahu mana yang terbaik.
Ikutlah, kita tak kisah points.
Kalau awak tengok Nano beraksi, awak nervous dulu. Nano doktor fashion.
Fashion.
Bagi Nana lah beraksi dulu.
Okay, Alia okay ke first?
Ikut je.
Okay.
Thank you Alia.
Nano tadi kiranya awak keluar balik
Saya keluar balik.
Oh, okay.
Sebab tadi Azfar pun dah masuk sekali, ingatkan kelas ke-8.
So kalau keluar balik kiranya rakaman tu tadi ada ke tak ada?
Oh, tak sure. Lepas tu tiba-tiba Azfar left. Lepas tu saya pun macam, kelas tak ada lagi ke? Okay. Saya pun keluar balik lah. Tak tahulah ada ke tak.
Okay.
Lapan suku dah. Mana semua orang? Oh dah ada dah. Doa tak ada lagi.
Doa dah ada.
Doa dah
Ada lah.
Fa.
Siapa lagi seorang? Oh Fa.
Fa.
Hello, hello. Hello.
Yes, faham.
Hello, dengar?
Dengar.
Jelas tak jelas?
Pelan sikit.
Pelan lah, tapi dengar lah.
Dengar.
Okay.
Assalamualaikum.
Waalaikumsalam, Doktor.
Waalaikumsalam.
How are you?
Salam.
Alhamdulillah.
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 Are you ready?
Yes.
Yes.
Hello.
Yes, Doctor.
Yes, Doktor.
Okay. Sorry, I was driving. I can't start on time. Can you send me, please, the name of the presenter today on my WhatsApp? And let us start by the first presentation, please.
Today, for the first presenter, Alia and me, Hanani, will be present.
Good.
Yes.
Okay, let us start.
Okay. Okay. Assalamualaikum. My name is.
Warahmatullah.
Okay. So today I will be the doctor. So Assalamualaikum. I am Alia. Yeah, year 5 medical student. So may I ask you what can I call you first?
Puan Hana.
Puan Hana. So Puan Hana, may I ask you about your child for why?
Oh, okay. So today I came to the emergency department since my child was fitting yesterday, which is in this early morning about during sleeping
During sleeping at what time?
at 3:30 a.m.
Okay. Just one day. Today only.
Yes, just today, 3:30 a.m. today.
So how long the fitting occur?
The fitting for eventually she was fitting a few times, and then for the first fitting, it only lasted for about 1 minute.
Okay.
Which is if after 1 hour from that fitting,
Mm-hmm.
and then after 1 hour from that fitting, she fit again, and then it was multiple times. The second episode was multiple times. I think which is more than 10 times.
The more than 10 times still have the interval 1 hour or it's non-stop?
No, the first episode was one times and resolved, and then
Okay.
after 1 hour, she fit again,
Mm-hmm.
and then this fitting doesn't stop. Like he keep on fitting, she keep on fitting for more than 10 times until I seek the treatment, which is at the emergency department.
So for the second episode, how long?
Okay, for the
The
second
duration.
episode, eventually it was the same. I don't think my child the fitting doesn't resolve. Even I think she couldn't respond to my calling. My child was 5 years old.
Okay. Oh, before that, your child. What is your name of your child?
Mimi.
Mimi. 5 years old.
Yes.
Okay. So for the means that I just want to clarify. The first one occur 1 minute, and then 1 hour after that second episode, and then the second episode it occur non-stop.
Yes.
So means it more than 1 minute.
Yeah, I think.
About 10 times.
Mm-hmm.
Okay. And what happened after the fitting? Did she have any like seem lethargy or weak?
Oh, okay. So after the fitting, she does seem lethargic, like unconscious, he been dozing, like okay. That's after fitting lah. During the fitting, since she does not respond to my calling, and then from what I observed, her upper limbs, both upper limbs and the lower limb was also stiff.
Both upper limb and lower limb. And is there any abnormal movement?
Usually the fitting, he keep the arms, both upper limbs and lower limbs stiff, and then move like, yeah, when you're in shock. I cannot describe that.
Okay.
I cannot describe that movement. However, I noticed that her eyeballs went upwards.
Okay. Is there any bluish lip? Bluish
Yes.
discoloration?
Her lips was bluish
Mm.
at that time.
Do you notice any tongue biting or saliva drooling?
No.
No. How about lip smacking? Do you know how it is?
No.
No. Did she had any incontinence during the episode?
No.
No. So, and you said that she doesn't respond to call. Do you think she is having loss of consciousness at that time? I mean, she,
During the 15th
yes,
episode, I think yes.
but no, after that,
After
how
that,
about after the
she
15?
I think she can recognize me, but she feels like dozy, like confused.
Okay. So prior to the fitting, did she do anything or she just sleeping?
Oh, from what I noticed, one day prior to episode, which is yesterday, like she doesn't really want to eat, and which is she had reduced in eating. Usually she takes she eat the porridge for
Mm.
one bowl. However, yesterday she only eat 2 to 3 spoon of porridge.
Mm.
And then she usually drink milk for about 2 to 3 bottles per day. However, yesterday she only drinks one bottle.
Okay.
Hmm.
Just for one day.
Yeah.
Okay. Prior to the, I would like to ask, prior to the fitting, is she before a day before that, did she experience any lack of sleep or any stress or any illness happen to her?
Oh, I'm not sure about that. Hmm. I don't think
Mm,
so.
during before the attack, did she experience any loud noise? Means exposed to any loud noise?
No.
Any strong light?
No.
Um, Before that, she doesn't have any fever, any
No.
cough, cold.
No.
Mm, did she? Did she? Do you notice any? I mean, um, like she appeared to have any changes in behavior?
Oh, no.
No. Maybe any tremors or colds, clammy skin.
Oh, I didn't notice that.
Do you notice any sign of no, I mean like dry lips?
No.
No. Sunken eyes? No.
No.
Okay.
Nothing abnormal.
Nothing abnormal.
I
So basically she just having the fitting and also the loss of appetite.
yeah.
How about medication? Did she took the medication?
Currently, she was not on any medication. I stopped taking. Oh, okay. My child usually this is not the first time she was having fitting. So she had a recurrent fitting for the past since she was at 2 years old.
2 years old.
Mm-mm.
So
That was the first.
how she presented at that time?
Oh, at the 2 years old, she presented with the same, just like the second episode of fitting this time, which is she had fitting multiple times. Uh,
Mm.
and then I went through the hospital, and at that time, my child was diagnosed with something Lepsy.
Epilepsy.
Yeah.
So after the episode at 3 years old, did she have any episode after that? Up till now?
Usually I think from that 2 years old until now, it's normal for her to have a 2 to 3 times fitting episode. And then she was on follow up with the hospital Kemamai, which is 3 monthly. However, I stopped going to the hospital for about 1 year, since I don't think that the medication that she received was curative for her. She keep on having 15 to 16 times per month, despite of taking medication.
So,
So I decided to go for homeopathy.
oh. So during the 1 year, did she become worsen?
What? No, it's just the same. But this time, it was same. Like for the past 1 year, it's only for 2 to 3 times per month. However, for this time, it's multiple times that does not stop. Usually, it stops for about 1 minute.
So actually, before she start to have the epilepsy at the 2 years old, did she had any trauma or any history of brain infection previously?
No.
No. Means it's occur suddenly without any.
Yeah, it occurs suddenly.
And then when the treatment, what do you know what treatment given previously?
Or she was on anti-fitting medication, but I'm not sure about the names of the medication.
Okay. So after receiving the medication, did she improve actually?
For the first time, I think she improved. However, for the long time, it just maintained the same, the level like 2 to 3 times per month.
So means you go to homeopathy at 3 years old.
Right. Since currently she is 5 years old, at the 4 years old, I
4 years
went to
old. Okay.
treatment for homeopathy.
And do you see any medical attention again? I mean that, do you complain to the doctor when your child is not improved?
Oh no,
No.
I just report the follow-up.
So the doctor never changed the medication or increased the dose?
No.
No. Okay. Mm. So other than epilepsy, you said that other than that, did she have any underlying disease?
Oh, okay. Eventually my child had like is different from the other normal child, since during when I was pregnant, during ultrasound scanning, my child the doctor told me that my child was having a small head. Uh,
Small. So it was diagnosed since?
Antenatal scan, there was a small head, right? However, when was she was delivered, and then when the doctor monitored her growth and also head circumference, and then the head circumference was not improving, so it's still a small head. I cannot remember the term that was used for the small head.
Okay. So how do you know the measurement, the head circumference for currently?
I'm not sure about that.
Not sure. Okay. So for that, the doctor had already done any investigation like MRI?
Yes.
Did they say anything?
I'm not sure about that.
Okay. So other than that, did your child have any problem with the development?
Yeah, yes. I'm not sure if it is related to the small head, but she had a development problem since she was at 9 months old. Since then, like she had a developmental delay. Until now, currently she is 5 years old, right? But she
Yes.
was still unable to walk.
Unable to walk. So what she can do?
Oh, from what she
I
can
mean,
do,
did she able to sit by herself or still need support, something like that?
okay. For the state, she still needs support. And then
Did she able to hold to eat by herself or to hold
no,
toys?
she need assistance to eat. I need to feed her.
How about
And
holding toys? Can she hold?
oh, She
Can
can
she
hold
hold something?
big toys, but not the small one.
Can she talk? Or
Uh,
how about
she just babbles or cry. She still cannot talk.
how about her interaction with other people? Means
Oh,
can she play or
for my part, since when she looks at me, she recognizes me. So she was friendly. She recognized some people that was familiar to her.
means
She is
she can
friendly.
recognize the parents, her parents, her
Yeah,
family.
yes.
Do you notice any hearing or visual problems? For,
Uh,
for
I don't think so, since she can respond to my call, like babbles.
so since she need help from means she need assistance, how about daily activities? Mean she cannot do any like
Oh,
bowel or
yes,
urinary.
she's still on Pampers,
Okay.
and I do everything for her.
So regarding the antenatal, actually before when you are pregnant with her, do you have any problems like
Oh,
infection or diabetes?
I got a GDM on diet during the pregnancy.
Mm.
Okay, I think that's all for my problem during pregnancy.
Or there's no other like infection?
No,
Do you take any drugs during pregnancy?
no.
No. So during throughout the pregnant, did you ever diagnosed with like I mean any problem with the fetus? Means other
Oh,
than the head circumference, like amniotic. Macam mana dah masuk?
no ada problem
Uh,
except from the small heat.
so uh, uh, so you give birth through
Oh, normal
normal. At
delivery.
what week?
Oh, at that time, he was at 38 weeks. She was
Mm.
at 38 weeks.
How about birth weight?
2.8 kilo.
2.8.
Mm.
Did you experience any complication or any
Nothing was eventful during the delivery.
postnatally? Is there any admission to the NICU?
Uh, no admission to NICU. She had jaundice, but only for
Mm.
about 2 days.
Mm.
No requirement of treatment.
So I'm sorry about the homeopathy you said earlier.
Yeah.
Uh, do you know what exactly the doctor give? I mean, what drug is given?
Oh, I'm not sure about that. Since my husband suggested me to go there.
Other than the homeopathy, she did not take any other medication.
No.
How about immunization?
Oh, she
Complete.
the immunization.
Okay. Did she have any drug allergy or food allergy?
From what I noticed, no.
No. Okay. I want to ask a bit about nutrition. So,
Mhm.
did she breastfed during the infancy?
I only breastfed her up to the 2 months old since I was busy working, so it's hard for me to breastfeed her. So since then, she was on formula milk, and then I started to give her like a soft diet during the 6 month old.
6 months. So, current diet,
Oh, current diet.
the portion.
She still cannot have an adult diet. So that's why she only eat porridge or soft diet.
So, means she cannot eat
Uh,
solid food yet.
yes.
How about the usual frequency?
For the porridge, usually one bowl, one bowl per day.
And also milk. She said
Uh,
still drinking.
Formula milk 2 to 3 bottles per day.
So during you feed her with the soft porridge, do you notice any difficulty? I mean, any like spillage of the food means you notice the child is difficult to swallow.
I think for the soft diet is okay, but for the solid, she really cannot take it. So she chop when eating solid food.
Okay. So how old are you, Puan Hana?
Yes.
How old are you?
Oh, I'm 30 years old. 30 years old.
Your husband?
34.
So this Masalah.
Mimi.
Mimi. Mimi is anak keberapa? Anak ke
Oh, usually Mimi is the only child.
the only child. Okay.
Um,
Do you know any family history of the same illness like the epilepsy or any neurological
no one
problem?
in my family having this similar presentation.
How about the congenital anomalies or any syndromic in the family?
No.
Is this a consanguineous marriage with?
No.
Okay. So, what is your occupation, Puan Hana?
I'm a housewife.
Housewife. How about your husband?
My husband a businessman.
Okay. May I know your household income?
About 5,000 per month.
So the Mimi is living with you and your husband.
Yes.
Yes. So where do you live?
I live in Kemamai.
And do the house have adequate basic amenities?
Yes.
Yes. How many story the house?
Just a single story house.
Single story. So Mimi is currently using wheelchair.
She's using wheelchair since she cannot walk.
I would like to ask, do you receive any financial aid? I mean, since Mimi is a special child.
Yes. We receive financial aid from the Jabatan Kebajikan, which is for about 600 per month.
So overall, in general, do you have any difficulty in taking care?
As a mother,
Financially.
Financially, I think it's okay for me since she is the only child in the family.
So Mimi doesn't go to any. I mean that Mimi is staying at home.
Yes.
Or did she go to any class?
No.
Do you have anything to tell me?
I think I for the first time why I did for the follow up is because I think that I thought that my child was not serious enough. This illness was not serious. Since this is my second admission eventually. The first admission was when she was 2 years old.
So, yes, yesterday when you came to the hospital, uh, what happened in the emergency?
Oh, the health workers, which is the doctors, inject empty fitting medication to my child, and then the fitting stopped.
So there's no other fitting episode after that
No fitting episode after that.
until today.
Yes.
Please, everyone non-speaking, switch off the microphone.
I forgot to ask. She doesn't have any diarrhea.
No.
No, that means no fever, cold, or any sign of infection. Just fitting suddenly, and then also had loss of appetite.
Yes.
Mm. May I know during this time for fitting, do you notice? So there's no any exposure to loud noise or lights prior to the incident, and also, did she do any activities before that?
No.
No. And she also able to sleep well before that.
Before the fitting occurs, she was able to sleep well.
And so a day before that also she
Yes.
adequate of sleep.
Yes.
And um, do you notice her like look lethargy or fatigue?
Fitting. Before that, I'm not sure about that.
Does Miss Mrs. Hannah, do you want to tell anything anymore?
I think that's
Maybe
all.
about the homeopathy.
Yeah.
So you already given for one year. And how about the frequency? I mean, how many times you give?
I usually go there for to seek treatment, like for 2 monthly.
2 monthly. Okay.
Okay, did you finish?
Yes.
Yes. Can you go 10 minutes, Fitraya, just to present your case?
Ada?
Alia.
Yeah, sorry.
Alia, sorry. Okay, Alia.
So, this patient, Mimi, a 5-year-old Malaysian with underlying epilepsy, microcephaly, and global developmental delay. So she is ADL independent. So she was presented to the emergency department with complaint of recurrent fitting episode for 1 day duration. So the fitting was associated with jerking movement and stiffness of both upper limb and lower limb, uprolling of eyeballs and bluish discoloration of lips. And post-ictally, there was drowsy and lethargic, but no paralysis. So the fitting occurred about 2 episodes. And otherwise, they also associated with loss of appetite for 1 day duration. However, there's no fever, no neck stiffness, photophobia, any loss, any cough, cold, vomiting, diarrhea, and also no changes in behavior. So prior to the incident, there's no head trauma, no exposure to any precipitating factor like loud noise or strong light, no stress or patient did miss medication since the past 1 year, where because her mother changed to seek for alternative treatment, which is the homeopathy since 1 year ago. So since that, she doesn't need, take any anti-epileptic. So my provisional diagnosis is recurrent epilepsy secondary to missed medication. So points for epilepsy is because she already been diagnosed with epilepsy previously. And she also had the symptoms of epilepsy like jerky movement, stiffness, and so on. And due to secondary to missed medication because she already stopped taking medication since 1 year ago. And for differential, it can be due to meningitis or any infection to the brain, meningitis or encephalitis, but this patient doesn't have any sign of infection like fever, neck stiffness, photophobia, and then other differential can also be electrolyte imbalance such as hyponatremia, but this patient but that need to be investigated further. But for now, there's no like diarrhea that could lead to the hyponatremia, and also other differential can be hypoglycemia and also space occupying lesion. And also another one is febrile fit, but again there's no fever, so it ruled out the febrile fit. So for the investigation, so for bedside, I would like to do the random blood sugar because hypoglycemia also can presented with seizure, and then for blood investigation, we can do full blood count to see if there is any sign of infection, and also blood culture and sensitivity if we suspect to have sepsis, because sepsis also can cause seizure. And then to rule out the electrolyte imbalance, we can do blood urea serum electrolyte.
Doktor dah tak ada.
Nah,
Pukul 9
Boleh,
dah guys. Alia boleh buat. Kita orang tanya soalan lah.
Yoski.
sampai bila doktor tak ada tadi?
Kenapa tak perasan?
Doktor dengar apa-apa tak? Okay.
Okay.
Hello.
Nah.
Did you finish?
Yes.
Okay. Who will be the one who will speak about the differential diagnosis of fits and convulsion? Did you assign anyone?
That would be me.
Yes, right.
Okay. Tell us, please, the cause. What is the positive points which we need to go through the history and the clinical examination, and even by investigation, and the other which can rule it out.
For this patient?
Yes.
Okay.
No. Generally, if patient has fits or convulsions.
Okay. So if a patient presents with fits or seizures, especially if they're afebrile, first of all, we have to look at the background and see if how long the seizure has been lasting, if it has been lasting for 5 minutes or long. And we have to keep in mind the known pathologies such as meningitis, trauma, or any hypoxic injury. And we have to watch out for cardiorespiratory compromise. We have to make sure that the child is breathing at all times and there is adequate circulation. So in the initial acute assessment, we have to, there'll be, assuming that this child comes to ED, there'll be someone managing the child, and at the same time, there should be, or as soon as possible, be someone who takes history from the parents, such as if there's any previous seizures before this or any anti-seizure medication, if there's any comorbidities such as having VP shunt or any structural brain abnormality. In this case, it will be microcephaly, or if the child has any endocrinopathies such as or renal failure, such as electrolyte imbalance or hypertensive NCAF. Then we have to look if the seizure is actually focal or generalized. This one we can, by assessing the type of seizure that's happening in front of us, or by assessing the history given by the parents. If it's a focal seizure, then it will be presented only on that is particular segment of the brain, or if it's a generalized seizure, such as a tonic-clonic seizure where the whole body is shaking, yeah? So we have to rule out trauma as well. and meningitis. So in meningitis, we have to rule out the Brudinsky and the Koenig sign if there's any neck stiffness, or if there's any photophobia that's given in the history from the parents, if you cannot or unsure of your assessment of the neck stiffness. So we can also ask about if there's any aura, any level of awareness of the child, and if there's any, for focal seizures, we have to ask for focality of the limb or eye movement, which means instead of it being general, let's say only one eye will be rolling upwards, or there will be a focal reaction in the a focal seizure, basically, example, like only one arm will be shaken. And we have to ask relevant past history, such as family history of seizures or any cardiac disorders. If there's any history suggestive of absent seizures, and the developmental history to rule out developmental delays or global developmental delay, just like in this child. So the red flags that we should watch out for are basically 6 red flags. If there is head injury, if there is developmental delay or regression, if there is headache prior to the seizure, if there is any bleeding disorder or anticoagulation therapy that's being used, if there's any involvement of drug or alcohol, and if there's focal signs. The differential diagnosis that we can consider in seizures can be arrhythmia, and in children, we can also consider breath holding spell, such as, which is an episode that occurs when a child is crying. So we have to ask for history of crying. And we can also consider vasovagal syncope with anoxic seizure, which is basically there'll be a postural change that is preceded with dizziness and nausea. So we have to ask for any history of instability if the child is walking, or any history of vomiting or complaints of nausea. And then we can also consider non-epileptic paroxysmal disorder, but I'm not really sure about that. But other differential diagnosis can be a pseudo seizure or a true seizure. So how we differentiate between a true seizure and a pseudo seizure, there can be differentiations based on features or lab findings. I will mention some. For example, if there is tongue bite, it's most likely a pseudo seizure. It's most likely a true seizure, other than a true pseudo seizure. But tongue biting doesn't always occur in true seizures. The true seizures are short duration, while pseudo seizures are of long duration. There is a post-ictal phenomenon in true seizures, such as drowsiness or crying, while in pseudo seizure there's no post-ictal phenomenon. There can be injury in true seizure, but most likely no in pseudo seizure. True seizures can occur during sleep, and there can be precipitated by the auras if it's focal. However, in pseudo seizures, they can be precipitated by suggestion if the child can understand Yula. Like, you can actually precipitate a seizure by suggesting or talking about the seizure. And in EEG findings for true seizures, there will be abnormal finding, and after the attack, there will be a slow pattern in EEG, while in pseudo seizures there is no change and during and after the attack. So after the attack, usually serum prolactin will be raised in true seizures, while there will be no raise in pseudo seizures. So for the management, obviously we have to give initial support, whereby in most situations we have to observe the child for 5 minutes while waiting for the seizure to stop spontaneously. Try to treat the child the way the parents treat at home. However, if you suspect a pathology, or if there is any suspect of cardiorespiratory compromise and the seizure is lasting for more than 5 minutes, or you don't know the duration of the seizure, but you assume that it's been going on because the parents can't give you proper history at that time, then you have to commence active treatment, which means you have to continuously monitor, always give oxygen, get IV access, and give benzodiazepines. If it's difficult to get IV access to give the benzodiazepine, then you can give IM or buccal midazolam. If after 5 minutes the child is still seizing, then you can repeat the dose of benzodiazepine. If another 5 minutes continues and the child is still seizing, then we have to consider giving a second line agent such as phenytoin or levetiracetam. And we can repeat this again after 5 minutes if the seizure is ongoing. However, at any point in time where if the seizure stops during our management, then we have to proceed to post-seizure care, which is comfort the child, revisit the history and examination, and go forth with the investigations and as required. So for post-seizure care, you have to position the child in a recovery position to maintain airway. The left lateral position is the one that is recommended. You have to monitor for further seizure activity and consider the investigations. So we can divide in the investigation into blood, neuroimaging, and EEG. So for blood, as mentioned by Alia just now, we can do random blood sugar at the bedside to check for any presence of hypoglycemia that might have precipitated the attack. We can also check for full blood count and blood CNS to check for any evidence of infection or evidence of sepsis, as well as blood urea to check for the serum electrolytes if there is any imbalance. We can also, to differentiate between a true and a pseudo seizure, we can also go for serum prolactin, but that is a bit expensive. We also, in serum electrolytes, we have to make sure that the child is not dehydrated, which is why Alia before this asked for the hydration status of the child. So in neuroimaging, we have to consider looking for MRI because if I'm not mistaken, in MRI we can see that we can rule out our differential diagnosis if there's any space occupying lesion, and if there is any congenital anomalies that have precipitated the seizures. Or in this case, because the child has microcephaly, we can try to rule out the differentials. And then we can consider EEG. It's rarely done in acute settings. It's actually not indicated as a routine test for all first seizures, but since this is not a first seizure, we can also conduct an EEG, and hopefully we can have some findings, because during the attack the findings are abnormal. After the attack there's a slowing pattern, but the findings can return back to normal if the child is during normal time, or like not having a seizure time. Any questions?
I have a question.
Yeah.
If the seizure is the first presentation, do we directly prescribe her any anti-epileptic medication?
If this is the first presentation, which means that the parents have never used any epileptic medication before this, from the flow chart that I've read, you have to first watch out for the seizure, and it depends on how long the seizure is going on for. So if it's going on for more than 5 minutes, then you start giving benzodiazepine. And as it progresses, then you try to step up your medication just to terminate the seizure. And then you can follow on with your investigations to see if this will be a recurrent and what is the precipitating factor.
Right, thank you.
Thank you very much. Can we go for Oski, please?
Okay. Can you hear me?
Kuat sikit Azfar.
Oh, kuat eh? Wait, I share the screen. Can you see the slide?
Yes, we can see it.
So, okay, for the first OSCE, who want to answer it? Any volunteer?
Lambang panca.
May I volunteer?
Yeah, yes. Yes, please.
Yeah, so this procedure, it is lumbar puncture. And then some indication for lumbar puncture, including meningitis, and then can be multiple sclerosis or any syphilis of the central nervous system. If there is any bleeding in the spinal cord, or can be also lymphoma or leukemia or any other cancer involving the CNS. Also, it can be used to drain spinal fluid to lower the increased intracranial pressure. Finally, contraindication for lumbar puncture includes high intracranial pressure. Can be assessed through signs and symptoms, any fundoscopic sign, any raised blood pressure, or if the patient has any bleeding tendency, and then the patient is unstable in terms of cardiorespiratory. Also, if the patient has focal neurological signs and altered mental status. And finally, it is also contraindicated if the patient has infection or any lesion at the site of lumbar puncture.
Yes.
That's all from me.
Okay. So, you're correct. So for the first OSCE, the procedure is lumbar puncture. So to answer the indications like very like systematically answering, so we can divide into diagnostic purpose and therapeutic purpose. So for diagnostic, all your answer is about diagnostic purpose. For example, if patients having probability to get infections or inflammations, and also in for therapeutic purpose, if patients for the infusion of chemotherapy, anesthetics, and also insertion of contrast. For contraindication of this procedure, as you answer it, so if patient is hemodynamically unstable, if the Glasgow Coma scale is less than 8, less or equal to 8, and also if patients having abnormal gross eye reflex, lateral signs, abnormal posturing, and immediately after recent seizures, and also if patients having papular edema, because there's evidence of increased intracranial pressure. Because of what? If patients are having like increase in intracranial pressure, so there's a risk for spinal herniation. Okay. So next, Oski, who want to answer it? Any 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 volunteer want to answer this, Oski? So this is a growth chart for head circumference. Head circumference.
Can I try?
Yes.
Sekejap, yang merah tu indicates the child punya growth
Yes.
So from this growth chart, the head circumference goes beyond the 90 percentiles. I think it has crossed 2 standard deviations of the normal variation of circumference. So, so other physical signs, maybe we have to look at the head. Maybe there is a presence of macrocephaly, and then the causes can be due to hydrocephalus. Ada physical sign. So ada physical sign for hydrocephalus, such as sunsetting eye, visible scalp vein, and then if all the children, we have to actually go to the we have to plot also for the width and the length and also the height to see these general conditions of growth problems or not.
Question number 3.
Oh, okay. Causal three. Terus. Causes of this condition. So it can be due to hydrocephalus, due to space occupying lesion. It can also be due to just a familial microcephaly, and also any infection. But infection is slightly.
Okay. So you are right. So describe the growth chart. So there's more than 90 percentile. And also other physical signs, you already explained that. Enlarged stance, anterior fontanelle, sensitive eyes, lid traction, dilated scalp vein. And then I think the causes of this condition, maybe you should you are answering in the correct way. Maybe I am wrong because this is like the causes for hydrocephalus itself. Because we can for hydrocephalus we can divide the cause into two, like communicating and also non-communicating. So for communicating, it can be bacterial meningitis, sarcoidosis, subarachnoid hemorrhage, head injury. For non-communicating, usually causes by aqueduct stenosis, tumors, colloid cysts, urinary malformation, and cerebral abscess. So I think Dahiyah answered it like the correct way. Okay. So next, Oski. This is the picture of um, electroencephalogram. So who want to try?
I try. So describe features. Basically, there is multiple generalized spike wave, spiking here, and then two condition can be due to epilepsy, and so for epilepsy, medication that we can give like the sodium valproate, lamotrigine. So, other condition, I'm not sure.
Oh, okay. So describe the features of EEG. So basically, there's a multiple generalized spikes wave. So basically, it's very hairwired on the EEG. So this is a condition for generalized tonic-clonic seizures. So the condition related to it usually is it can be epilepsy and also any conditions that can cause seizures or abnormality to EEG. We can include, for example, the probiotic, something like that, like that patient presented with seizures, and then medication can use to treat this. So for epilepsy, you know that for generalized tonic-clonic epilepsy, the first line is we can give sodium valproate, and if the first line did not work, so we can add lamotrigine. But we should consider monotherapy first, because if monotherapy did not work, so we try to add another anti-epileptic, and we try to like um, uh, kurangkan like reduce the dosage of the first anti-epileptic that we given. Okay, so we given so we try to give like monotherapy. Okay, so next, Oski, who wants to try? It's about developmental assessment.
May I try?
Yes, you can try.
Okay. So from what I can see, the child for the ghost motor, the child can sit without support. And then for the fine motor, he was able to build 4 blocks. Okay, so for the seat without support, so it is 9 months old. For the fine motor, so he can do a 4 block, so it is more than 18 months old. So I think uh, that's the only information that I can get from the picture. So between the 9, I'm not sure what he can do. So I suspect 9 to 12 months.
If it is based on the fine motor itself, so what's the
Oh,
expected?
if based on the fine motor, I think it's 18 months old at least.
Okay. So next question.
What aspect able to do? So they want to give this child 18 months old. If they're 18 months old, so for the ghost motor, the child can able to walk normally while carrying the toys, and then uh, he can already show the 2 to 3 parts of the body part, uh, and then can say 2 to 3 words, intelligible words. Okay. Mm,
For the social behavior, for 18 months.
for 18 months, social behavior. Mm,
So, so basically this is the answer. So so this expected like Fitria answer. So because for 18 months basically for the fine motor this the babies the patients can like do a tower of 3 cubes. For 2 years old the babies can do a tower of 6 to 7 cubes. So I think it's between 18 months to 2 years based on the fine motor itself, but we need more information for this patient to really like set the expected age, and then what else it is expected the child able to do. So we take the 18 months. So for the gross motor, like Fitria answered, so for gross motor, patient can walk up and downstairs with helps, and then patient can squats to pick up toys for gross motor, and then for the fine motor, like he can do the tower of 3 cubes, and for the speech, patient can like point 2 to 3 body parts, and then have 6 to 20 in intelligible words, and also for social behavior. So patient can imitate housewords and use the spoon well. However, patient needs for dressing, patient will need some assistant, will assist with dressing. Okay. I think that's all for the OSCE. Only 4 questions. Okay, thank you.
Okay, thank you. What is the neurocutaneous syndrome?
Neurofibromatosis, tuberous sclerosis.
Yeah, I am asking. Where is the OSCE for that?
Oh, I'm not included. Include the
Speak before that the next system in our thinking every time must be present. The couple with CNS usually is skin. Okay, so I need just to give you a simple comment. I am trying to leave you speak all to get feedback. Soon you are going to be practicing, and our mission and vision must be how to be deep. How can we go for more details and make use of every part? So let us start by Aliyah. You told me the diagnosis of epilepsy. Is it enough?
No.
Yes. Why?
Because I need to mention the causes.
Yeah, even before the causes, the mother told you the patient has microcephaly. Is it a separate diagnosis or not? Okay. What about the global developmental delay? Is it a diagnosis?
Yes.
Okay. So at least we have
Okay.
a lot of issue when it looks it is like the one who give you a manna, the patient give you details, and you are trying to transfer it to the other. You must give all amana. So the patient has complete diagnosis. I mean, he has a known patient of epilepsy, okay, with microcephaly, okay, with global developmental delay, presented by status epilepticus. Now we are making use of the point which come to us from the patient, because every word of this, it has an important decision. What is the investigation? What is the management? Does the patient need any intervention, either admission or multidisciplinary team for his eye? This is number one. Number two, it didn't also the point which speak about differential diagnosis. Who did the differential diagnosis? Is it Dua? Dua?
Yes, doctor, I did.
Yeah, you have a good confidence and a good presentation, but also we need to be, as I told you, we need to be comprehensive. You try to speak about fits and the non-fits, yes. Especially it is not so common in pediatric population, but we must rule it, especially if it is adolescents with some problem like that. If the child very small, we are speaking about breath holding syndrome. But in pediatric, we have something known as condition mimic fits. And if you open Nelson, you will find a very big Nelson 1983. I was studying about 17 to 20 differential diagnosis of fits, as you speak about arrhythmias, about cardiac, about many issues, okay? Tics, about others. Now, the table will be very long at that time. So we must speak about two differential diagnosis between fits and other condition which mimic the fits. This is number one. Okay. Number two, we are trying to speak about the causes which must be considered, like meningitis. Okay. If Aliyah need to speak about meningitis, you must ask, does the child get any stiffness of his neck? He is moving his neck normally, or he feel a pain, who cannot flex it. Okay. He can bend down or not. He has any abnormal position. Okay. Causes of epilepsy, Dua, you didn't speak about also neurocutaneous syndrome. As I told you, your responsibility is to ask what is the second system which I am going to manage, to examine. So you didn't touch this neurocutaneous syndrome and its presentation. Now also, before we have very funded by only neurofibromatosis, but now it is more than 10 neurocutaneous syndrome known. I know in your situation you mustn't know all, but at least you must know hint about the neurocutaneous syndrome, what is the most common, what is Sturge-Weber disease, what others, like that. Okay, so it is very important to put it in our differential diagnosis, to think globally, because even if you have any symptom like cough, you will see 1,000 patients, all are coughing, but every patient in his merit has his own presentation. Okay, it is very important. If convulsion, also it is not one symptom. Yes, it is one symptom, but with thousands of presentation. So you must be able to take care about that. Okay, and all this must be reflected in the history. I mean, here during the history, I must ask them. If the patient in front of me, of course, I will get a look to the skin. If I am asking the history, I will ask the same question. Is there any abnormality in the color of the skin? Like that. Also for the global developmental delay, if the mother said my baby is delayed. So I must know that developmental assessment is not one item. It is 4 items. Yes. What is these 4 items?
Gross motor, fine motor,
Okay.
and social.
And the fourth is the social. So you must be able to comment about all that. If you need to speak about development, even your colleague bring you some motor movement, so you can comment about this is the gross motor. I would like to check about other fine motor with vision, and as I told you, not to forget fine motor with vision, okay, speaking and hearing and social. So this is my point for your, inshallah, near practice, how you polish our knowledge now and to make it more practical, more comprehensive, how we are handle that one. Because if someone finish his duty and he need to endorse the cases, to make endorsement to his coming colleague so he can go home and the other one can concentrate in his job, I need to make it like a piece of cake completed. His patient has 1, 2, 3, 4 problems. Our concern now about status epilepticus. No one asked the mother, which is Dr. Fitreya, no one teach her about that epilepsy, how to do when, because she is non-epilepsy. Anyone, because you must document. If no one did it before, okay, he did the wrong, but now it is my responsibility. No one taught you what to do if your patient got epilepsy. Okay, they informed me. Okay, anyone inform you that sometimes of epilepsy need long-term treatment, at least 2 years or more, and mustn't be treatment stopped by anyone, only by the doctor, because cutting the medication abruptly can cause persistent conversion. The patient doesn't know what is status epilepticus. It can cause persistent convulsion, which can be life-threatening and can affect many organs in the body. No need to say something which make the patient very panic, okay? So it is very important also our thinking about every symptom. That's why we are teaching you from the start about every system, what is the most common complaint, and how we can go deep for that, and how can we search for that. It is very important. Now you have another responsibility. You ask it the treatment, the mother doesn't know, but you must know. What is the shape of this medication? Sometimes I need to open the internet with some picture of the most common anti-epileptic drug like tibaquine, like phenytoin, like whatever giving now, Kepra, all this. I must be able to present that to the patient. Is it the one which you are giving? How many tablet or how many syrup, like that. And we must ask ourselves now about the new anti-epileptic drugs. Now there is evolving of the medicine. Before, when we started treatment, we are very happy that we have phenobarb and phenytoin. And when valproic acid start, we are very, very proud about that. Now we have a lot of medication and a lot of subspecialty. This one can treat the generalized, this one can do the absent, this one can do like that. So please, your responsibility is to go deep, go for details. And these details, it is not for fun. It is really one patient will meet you with this detail. And you must make sure, make feedback about that. Okay? For our slides, please. Can you just present it rapidly, the OSCE? Hello? Okay. Yes. So now contraindication is very important. Okay. Indication of procedure, you speak good about it. But you yourself, I think you are the one who presented some cases of uh, acute paralysis,
Yes.
which we can do for it, lumbar puncture. What is this?
For the Guillain-Barré syndrome and also for the multiple sclerosis.
Yes, and even polio. So it is very important, Guillain-Barré syndrome, to know what is there for protein dissociation, like that. Don't forget that some inborn errors of metabolism can be diagnosed through the CSF for hyperglycemia. So it is very wide. That's why I am telling you we must build up our knowledge. Now it is knowledge, but after few months, it will be in front of your eyes and you ask yourself, oh, is it the one which I read? I am seeing it now. رأي العين حقيقة. Actually, I am seeing it. Okay. Also, how many bottles you are going to collect? Because we presented it before. Okay. At least 4 bottles. Sometimes you are putting extra bottle for us. Internal medicine sometimes requiring more and more because they are diagnosing more condition, but at least it is 4. And you must know the first bottle for what, second bottle for what, third bottle for what, and what's the fourth bottle, and why we must keep some of this. Okay. Second, Oski, please. Yeah. As we speak before, please, if you find any patient crossing the centile by more than 2, whatever, up or down, you must be worried. At this situation, because I saw some doctors make panic to the family. Please, whatever you are suspecting, you must keep quiet and try to tell the family this looks abnormal and I need investigation. And the first investigation here for big size head is familial. Again, familial. So you must at the on the spot go and measure the head circumference of the mother and the father and plot them on centile chart. Okay, sometimes some congenital anomalies like Soto syndrome can do like that. Okay, then we are considering hydrocephalus, whatever the other causes. So considering everything, is it variation from normal or not? Okay, of course, treatment of hydrocephalus is what is the treatment of hydrocephalus? Sorry, VB shunt. Unlikely, I saw a lot of students missing the shunt. Examine the head, yes, he is examining. And they forgot to palpate for the AV shunt, especially some Malaysian kids have a nice hair and a lot of hair, so he is not keen to palpate for that. It is very, very, very dangerous to miss it. So in every patient you ask to examine the head, you must palpate by your hand. Yes, see by your eyes and palpate by your hand. It may be under the skin, you cannot feel it. And even you need to palpate any chunk. Just put your hand to see, is it hot or not? Because it may be inflamed, hot and tender. Sometimes you must know how to check, is it working or not, just by simple pressing. If it is already, when you press, it is malleable with you and it refill again, it is working. But at your stage, this as undergraduate, no need to try to do that. But you can mention there is no signs of infection. I would like to check, is it working or not, by see, is it very tense? I can, if I press, see if will go down, and it will refill again like that. It is very important. Okay, so please don't miss and don't forget during the examination, which is, I think there will be one of you present a short case. Examine the head is very important, the size of the head, but while examining the head, I must also concentrate about the anterior fontanelle, the posterior fontanelle, the sutures, okay, the reservoir, the hearing, then I will go for neurocutaneous like that. The third OSCE, please. So what is this diagnosis?
Generalized tonic-clonic seizure.
Yes, we can say generalized, but does it looks like hips arrhythmia?
Hips arrhythmia.
Yeah.
Because hips arrhythmia is a specific diagnosis. Do you know? That is my advice you before. You must know something about everything coming to you. Like EEG, I know that it is be difficult for you, but you must know at least the type of spikes which we can have, and there is about few 6 or 7 very famous EEG forms. Like hips arrhythmia, it is related to which disease?
West syndrome.
It is very important, and its treatment we must consider. Beside anti-epileptic if needed, sometimes it is responsive to to cortisone. So it is very important. Also, we have the spike of absence, which is 3 in second. It is very important. There is some common forms you must know about that. Okay, tuberous sclerosis, like that. Okay, two medication for okay. If it is general, yes, you can define that. But if it is speaking about hips arrhythmia, the specific medication here will include steroid, okay, or X. The next one, yeah. So your colleague comment about this gross motor, but she didn't try to count how many cubes, and the patient looks looking uh, at the one in front of him, so we have action and reaction. Please, it is very important when you are prescribing a baby to say he is active and reactive. Active, I will define his age. Reactive, I will define his state. Is his autistic child or a special child or like that, okay? So remember every time to speak about is the patient active and reactive. He looks reactive and he looks trying to use his finger, not the palm, and it must give you some clue also for the other. So medicine will teach you with time how to be diplomatic, like sorry, like every trade. So it said, oh, this child sitting is doing like that, but I can find 1, 2, 3, 4, 5, and I can see him gazing at me and he's catching by the thumb. I think his fine motor may be also assuring. I would like to make more specific for fine motor tests. His vision looks okay, but I would like to check vision and the hearing. It is not just how to present, but really this is your responsibility. Okay? So you will not be lost during the exam time. The last one, or this is the last?
This is the last.
This is the last.
Okay. I hope you picked the point, please.
I'm sorry,
Now,
Doctor.
yes.
Can I ask about the active and reactive? Can you explain a bit about it?
For any child, let me speaking to you now. I have one patient of cerebral palsy. He is 9 years old. Okay, he may have some activity, but is it enough? No, he is active. He can move his limb, but he has paucity of anti-gravity. Okay, so I will say he has some activity, but his muscle power looks like 3/5. Okay, and he is not reactive. If I call him blah blah, he will not respond. Okay, what does it mean?
They have hearing problem.
May have hearing problem, but even without hearing problem, the patient doesn't communicate, so has the center already insulted. Okay, so it is a one. So that how can I confirm that he doesn't have eye-to-eye contact with me? He has his own world. He is crying and smiling on his own without reaction with the circumstances. Okay, and he still have OGT tube to feed, and his voice looks like that. I think he has lower motor neuron paralysis, pseudobulbar like that, and he's still wearing pampers, so he has no continence. So all this will guide me that he is a special child. He is not normal for his age. Okay?
Okay.
If I came to child with 3 or 4 years and I'm trying to get his attention and he refused completely to give me eye-to-eye contact. And I asked the mother, yes, he has monotonic. He needs this to play this only play. And if one touch it, he will be very upset like that. And his speaking is not good. So I may consider this child has like autism or autistic spectrum disorders. So by observation, is any child while you are examining is active and reactive. Okay? Minji reaction, if you call him hi, Ois, said hi, or smile, or even afraid and escape from me, no problem. But he has reaction if he's still young and have stringent and anxiety like that. But if he didn't, it's very dangerous. If the patient, you look to him, even if he's just delivered, have 2 months like that, and you look to his eyes and he doesn't look to your eye, it is very dangerous. He may be blind and do no one know because the eye is moving. So you must ask the mother, Mom, he is gazing at you or not? She may say yes. Should really, I feel that he is not gazing for me. He can only hear my voice and smell my milk like that only. So it is very dangerous. If I didn't pick it, maybe the child has problem in his eyes. So this is the important. Am I clear?
Yes.
Okay. I will keep the presentation of a short case of neurology after you will start now. What is the second case?
Shall receive.
Okay. Okay. So you will got 20-minute present. Okay. And 20 minutes for differential diagnosis or less, and about 10 minutes for OSCE, and I will discuss at the end. Okay.
Okay. So I will
Okay.
give a question.
Yes. Who?
Nadira.
Okay. يلا سيد بسم الله.
So, my name, Assalamualaikum. My name is Nadira. I'm gonna be the doctor for the second case. Everyone can hear me loud and clear, right?
Yes.
Okay. Okay, thank you. So, Assalamualaikum Puan.
Waalaikumsalam.
Boleh saya may I know what is your
Sorry, Nadira, I cannot hear you well.
may I know what is your name, Puan?
You can call me Puan Nur.
Puan Nur, okay. Puan Nur, my name is Nadira. I am a fifth year medical student. So I'm gonna ask you a certain question regarding what brought you to hospital. May I know the reason of it?
So today, I bring my child, my boy, Omar, 11 months old. So the reason that I came today because I'm worried of he had fever since 5 days ago, and last night I noticed that yesterday I noticed that there is a rash all over his body. So that's why I come here today.
Okay. Uh, okay, before I ask regarding the rash, may I know a little bit more about the fever? Does it
Okay.
occur suddenly, or do you notice that he got some transmitted infection from other family members?
No, because he is my first child. So I think since 5 days ago, the he suddenly got fever. I feel the body suddenly feel warm and hot, and no one else in our family is sick prior to that.
Okay. Do you have any recorded temperature regarding the fever?
Yeah. On the first day, I the temperature is about 38, but since last night it spiked up to 39.5.
So this temperature was recorded at home and not by any general practitioner.
Yesterday, before came here, I went to GP, and also at the GP, the temperature recorded about 39 degrees Celsius like that.
Okay. And then may I know, Puan Nur, does you notice your child have shown any sign of shivering?
Yeah, I think at night, especially at night, he become more the body become shivering, and then he feel like irritable, discomfort.
How about the food intake for the 5 days? Does he take any food or add drinks normally?
So since this 5 days also, there is a also reduce in his appetite. Previously, he had just a normal diet. He can tolerate. Currently, he can tolerate like chicken and meat. But for the past 5 days, he just want to eat a very little amount of food.
Okay. Does you notice any drooling or saliva around the mouth?
No, I not noticed that.
No. Okay. Does he show any sign that he have some toothache or any problem with the mouth?
I don't notice any toothache, but I think the lips had become dry, and I'm not sure it's just normal when our child is sick, but because it's my first child, but the tongue appear very red. I'm not sure is it normal or yeah,
You
but
can
it
see the.
appear red.
Does you notice any cracking around the mouth area or at the lips?
Sorry, can you repeat?
Do you notice any crack seen at the at the lips area?
Yes, yes. There is the lips is dry, so it look crack.
Okay. All right. Since the onset of the fever, may I know that if your child have any cough or sneezing?
Oh no, he doesn't have any of the symptoms.
Okay. Only fever throughout the 5 days.
Uh, there is fevers, and yesterday, I noticed there rash,
Oh,
which caused me to worry more about
okay.
him.
So he become more irritable since the onset of the rash?
Yeah, he
Okay.
appeared very cranky, discomfort.
All right. Okay. Just a little bit more about the fever. So, may I know what Puan Nur done to trying to relieve the fever? Did you give any medication to Omar?
Oh, yeah, I give him a PCM, paracetamol, but I think it just reduced the temperature for a while, just for a temporary that, and then the temperature spike again. It's not really
Okay.
helpful, this my child.
Okay. How about any tepid sponging? Does you try any of that method?
Yeah, also I put some wet cloths, but also it doesn't give much relief to my child.
All right. Okay. But there's no vomiting except for the loss of appetite, right?
No, there's no vomiting.
Okay. All right. Moving on to the regarding the rash, Puan Nur, may I know, where do you notice the rash initially start?
So initially I noticed there is a rash at the chest area, and then last night, the rash become more extensive. It spread to the back and also back of his head.
I'm sorry, back of the body and back of the head.
Yes. Yeah.
Okay. Any other area? Do you notice? Is there any?
Mm, no,
Yeah?
that's all.
Okay. No other rash at the limbs, at the hands or at the foot.
No.
Okay. All right. Okay. Do you notice any swelling around the neck of Omar?
Swelling. What do you mean swelling?
Any noticeable swelling around the neck of Omar?
Oh, yeah. I think I'm not
You
sure.
can.
Is it
Mhm.
swelling or just a lump like that at the
Okay.
neck area? But only once. One bit. There's a lump.
Okay, you notice a lump and you only notice this since the onset of fever?
Yeah, I think he didn't have it before.
Okay. May I know which side, right or left neck?
I think on the right side.
Okay, at the right side. All right. Okay. Um. Since Omar already 11 months old, may I know that did he already can speak things like complaining that he in pain or have any feeling apa, pruritus?
I'm sorry. Um,
Can Omar complain that he is in pain? Can he speak and tell Puan Nur about it?
uh, he still cannot speak well, but
Okay.
I noticed there is some changes of the behavior that told him that maybe he was really in a very discomfort situation, because he is very irritable,
Okay. Is there any changes
that
in
he
terms
doesn't
of?
want to eat.
Oh, okay. All right. Okay. Is there any changes regarding the bowel output of Omar? Does he experience
There's no
any?
changes for the bowel output, but I noticed there is um, changes in his urine output. Urine output.
Okay. May I know what the changes
Since
is?
the since the past 2 days, he just wet about half of the diapers. Usually, I'm not sure usually, but there's a reduction in amount.
Okay. Yeah. You notice that there is a reducing in amount of his urine.
Yeah, fewer diapers was used for the past 2 days that I noticed.
Do you see any stain on the diapers, like red stain or anything?
I don't think so. No,
Okay. All right. Okay. How about the bowel output of Omar? No changes at all.
no.
Now, may I know the normal frequency of his bowel output?
Usually about two to 2 to 3 times. No, sorry, 1 to 2 times per day.
Times a day. Okay. All right. Okay. 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 For Nur, may I know for the before the onset of the fever, did you travel anywhere with Omar? Maybe just come back from the overseas or
No, since PKP we are just at home.
okay. May I know where did you live?
So currently I live in Indramayu Kota 2.
Okay. So no traveling so far.
No.
Okay. Uh, uh, Omar doesn't take any. Did Omar take any immunization before the onset of the fever?
No, there was no recent immunization.
Uh, no recent medication that he took.
Except for the Panadol, I don't give him any medication before.
Okay. May I know if Omar have any underlying illness?
No, previously just healthy boy. No any medical problems.
Okay. Do you notice any bleeding around the side of the mouth?
No, I don't think so.
Okay. No bruises. You cannot see any
No.
bruises. Okay. Only rash.
Yeah.
What is the color of the rash, Panur?
Red color.
Red color. Okay. All right. So you brought Omar due to the to hospital due to the rash because you worried about the rash or because of the worsening of the fever.
Yeah. I'm worried both because the fever does not resolve, does not relieve, and also the rash that become prominent yesterday. And also, doctor, just want to add, I think there is also a red discoloration of the eyes of my boy.
Mm, I just about to ask that. Okay. Red color. Do you notice any fluid coming out from the eyes?
No, no fluid coming, but just appeared red.
Just a bit red. Okay, both eye.
Both of his eye. Yeah.
Okay. And this occurs since the onset of the fever also.
Yeah.
Okay. All right. Mm, okay. So currently, his immunization is according to the schedule.
Yeah.
Okay. Since Omar already 11 months old, May I know, can he walk already?
No, he just can stand and
Okay.
then holding to finchers, but he cannot walk yet.
Okay. Okay. Alright. Is it okay? For the birth history of Omar, may I know how do you have any complication during the pregnancy?
No, there's no problem except that he born via cesarean section term, but
Mm-hmm.
otherwise there was no other complication following that.
Puano doesn't have any medical condition during that time.
No.
All right. So that's after the birth of Omar, does he have any complications such as prolonged jaundice?
He had jaundice, but only I think about 3 to 4 days, and then it's off.
Okay. Not getting admitted.
No.
Okay. For the is there any medical problem in family, Puan Nur?
What medical problems?
Such as any family members that also presented or having similar symptom like fever and rash?
No.
No, okay. May I know how many members are living inside the house?
So I currently just living with my child and also my husband.
Okay, only three
Yeah, and
of.
3 of us.
Okay, none of you. Yeah, both of you have been traveling so far.
No.
Okay. Do you hear any recent recent cases of dengue around your area?
I think no. There's not any recent cases reported.
Okay. You also doesn't notice any yellowish discoloration on Omar at the eyes.
No.
Okay. Okay. Do you know is there any family members who have any blood problem? Why no?
No. All my family members are healthy.
Okay. Is there any more you want to tell me, Pano?
I just want to add. I think my Omar's had some swollen hand and feet also.
Swollen hand and feet.
Yeah.
Okay.
So I just
But
worry, is it I think affecting his heart or not?
okay. Do you notice any insect bite around the area of the swollen?
No.
Okay.
Just that it appears big and swollen.
Okay. Does Omar ever experience any signs of allergy towards the food or medication that being given to him?
No, I'm not. She had no any allergy before.
Okay. So no shortness of breath occurring during this period of illness.
No, there's nothing like that.
Okay. Do you still breastfeed or Omar?
Uh, Currently, yes.
Okay.
But I already introduced with other complementary food.
Food. Alright. Can Omar already start to uh call you or your husband, like form as one word?
Yeah, he can speak one word and we can understand it. Only we can understand it.
Only the parents can understand it, right? Okay. Uh, so okay.
20 minutes already.
All right. Should I stop here? Can I continue?
Do you have anything more to ask, Doctor?
Do you notice Omar has lost any weight?
Oh, I'm not sure about that,
Okay.
but I think just normal for me.
All right. Okay. I think yeah, that's all the question that I want to ask. Okay.
Okay,
All right. Thank you very much, Nur.
all right.
Okay. So, Doctor, should I present my history now?
Is doctor here? There are only 10 people.
Tak ada doktor.
Tak ada. Hi.
Okay, so Puan Nur, do you child have any abdominal pain or any rat infestation notice at home?
No,
Okay, good.
no abdominal distension.
Thanks. Okay, good. No SOB. Okay. Noted.
Doktor tak ada.
Okay, macam mana? Takut lah. Macam mana? Sekejap, sabar. Exam macam ni? Sabar.
Fever tak tanya pun yang pattern.
Itulah. Terlalu lupa nak tanya.
Nadi, pasal fever semua tu, and then dia ada lump. I think you need to rule out TB lymphadenitis sebenarnya. Night sweat.
TV. Oh, okay.
Sebab dia banyak simptom kan actually, tapi rule out je lah.
Alright.
Dia tanya B symptom juga.
Epstein-Barr virus.
Mak, ada tak night sweat?
Tak ada.
Ada, okay. Ada kontak dengan TB patient tak, Mak?
No. Ada
Okay.
BCG scar.
Ada juga, okay.
Okay.
Nak tadi sakit tekak Mak sebelum demam.
Sakit tekak. Mak ke
Anak.
anak?
Anak.
Tak ada. No. Tak tanya ke duduk nursing care ke tak?
Duduk nursing care ke, Mak?
Yes.
Oh, duduk nursing care.
Mak kerja ke?
Apa?
Mak,
tak penting.
Mak kerja. Mak study.
Anak-anak tu yang red tongue tu strawberry tongue ke apa?
Possible.
Possible. Beret-beret semua tak ada. Alah lupa nak tanya. Omar boleh gerak-gerak kepala macam biasa tak?
Yes, can.
Alright. SSP ada fever ke? Fever. Ada kan?
Sorry, doctor, we already finished.
Sorry. Okay.
What happens?
Doctor, we just finished. I just finished clucking the mother.
Hello?
Hello, doctor.
Okay. Yes, can you tell us? Yes. Can you tell us what is the diagnosis? You can go 10 to 15 minutes. 10 to 15 minutes to speak about your diagnosis, please.
Should I present the history first or just directly mention the diagnosis, doctor?
Now consider yourself in the exam and you got the offer to do whatever you wish. So check which is the best for you. Okay, 10 to 15 minutes. After that, we are going to present the OSCE and start our discussion.
All right, doctor. So regarding my patient, may I start, doctor?
Okay. Yes, go ahead.
Okay. Thank you, doctor. So regarding my patient, Omar, 11 months old, male, male infant, no medical illness, was brought to emergency department with a complaint of fever for 5 days duration. And associated with rash 4 months prior to the presentation. So regarding the fever, it was sudden in onset and it was warm, with documented temperature at home was 38 to 39 Celsius, and it was worsened especially during the night with association of shivering, and it was also associated with irritability and complaint of and the child look discomfort. The mother deny any engagement with seat contact, and they made for in order to relieve the fever, the mother used paracetamol and tepid sponging. However, it was just a relief temporarily, and it since the onset of the fever, the mother noticed the child to have a decrease in appetite. Usually he will take chicken and meat as the favorite meal, but during the period of illness, he just take a little amount of food, but the mother denied any drooling or saliva noted, no vomiting was presented at that moment. Other than that, the mother also deny any preceding symptoms of upper respiratory tract infection, such as cough, sneezing or running nose, and the mother also deny any history of recent traveling. Okay, other than the fever, the mother also noticed there is a lump, uh, at the right side of the neck of this child, but there is no association with night sweat. There is no contact with the TB patient, and uh, for the bowel output of this patient, it was normal, no changes in bowel output. And the urine, however, for the urine output, since the 2 days of the since the 2 days onset of the fever, mother noticed that the amount become minimal, with the evidence of the diapers was just half 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 full for every time it change, the mother change, but no any red stain at the diapers. Okay. There also lips presence of dry lips and cracked notice around the lips area. The mother also said there is a red color of the tongue of Omar. However, the mother deny any yellowish discoloration of skin noted, but there also red color of the eyes, bilateral red color with no fluid discharge. Okay. Progressively, 1 day prior to the presentation, Omar developed a rash. It was reddish in color. It started initially at the chest, but then spread to the back of the body. No no other side of involvement noted by the mother. And since then, the mother also noted that the child have a swollen hand and feet, but there is no evidence of insect bite noted by the mother. So far, the mother denied that Omar take any recent vaccination or medication prior to the onset of the fever, and then there is also no bleeding tendency noted. Omar doesn't experience any SOB and nor abdominal distension noted. Okay. So moving on to the birth history of Omar. The mother doesn't have any
Tak
complication.
ada.
Sorry? Sorry, Dahiyah?
Doktor tak ada.
Doktor tak
Doktor
ada.
tak ada.
Okay.
Sekejap. Perlu ke cerita pasal birth ni semua?
Doktor dah ada dah.
Okay. So, my working diagnosis currently at this point would be Kawasaki disease due to the criteria of the fever, fit more than 5 days, and it also fit the there is also presence of conjunctivitis, bilateral conjunctivitis. There also presence of rash, and there also a rash swollen at the right side of the neck that I might suspect it to be adenopathy, but I need to confirm through my physical examination. There also mucosal involvement from the history, red tongue, and there also edema at the extremities based on the history that I need to confirm through my physical examination. So my other differential diagnosis would be meningococcemia due to presence of the fever and the rash. However, there is no a patient still can there is no history suggesting of neck pain, and patient still not ill looking based on the history. And other than that, my other differential would be HS. No. Measles. My other differential would be my other differential would be scarlet fever due to presence of the fever. There is also tongue red that I might suspected for the strawberry tongue, scarlet fever, and the rash. However, I need to do physical examination to discriminate the type of the rash. That's for the differential diagnosis. Should I proceed to the investigation, doctor?
Continue, please.
Okay. Before I proceed to the investigation, for the what I suspect for the physical examination. So generally, I expect the patient to be irritable based on the history of the mother, and the vital signs for this patient for my differential. Since my working diagnosis was Kawasaki, I not expect patient to be in shock. Maybe patient and I want to do a ENT examination to see the presence of bilateral non-exudative conjunctivitis and examine the oral area of the patient to see any dry, cracked lips, strawberry tongue, and then I want to check for the leaf adenopathy, especially at cervical area. So I expected it will be unilateral um, leaf adenopathy, cervical leaf adenopathy, and I want to elicit any neck tenderness since one of my differential would be meningococcemia. Uh, I want to do a skin examination. Look for the characteristic of the rash. So I expected it will be palpable purpura, um, palpable purpura, and then uh, uh, a red papula. Okay, red maculopapula was a blanching type of rash. Okay. And then I would like to inspect for the cardiovascular examination. Expected a normal finding of the cardiovascular, except that if patient already developed some complication, maybe. And then check for the abdomen of the patient. Should be soft and non-tender and no other abnormalities in other system. So to confirm my working diagnosis of Kawasaki disease, since Kawasaki disease is a clinical diagnosis, so it fit the criteria that I mentioned before. So to rule out other differential, first I would like to take blood to do blood investigation, do the full blood count, to see any raised level of leukocytosis and to see whether lymphocyte or neutrophil increase, to differentiate whether it is a bacterial or viral infection, and look at the platelet level. I expected it be thrombocytosis for the Kawasaki, and then other than blood count, I would like to do a liver function test to maybe there is some evidence of transaminitis and hypoalbuminemia, secondary to vasculitis, and also the renal profile. The patient have decrease in appetite, so need to see any electrolyte imbalance or signs of AKI due to decrease in oral intake. And then okay, and then I would like to do a coagulation profile to rule out any coagulation disorders, especially may have purpura. And then in terms of okay. And then I would like to do bedside investigation such as ECG to rule out any signs of pericarditis secondary to Kawasaki. However, from the history, is not that suggestive that patient have already developed any complication from that. And then I would like to proceed with imaging of echocardiography to rule out any coronary artery involvement secondary to Kawasaki disease. So in order to rule out my differential of meningococcemia, I would like I would consider to do lumbar puncture if it was indicated. I think that's all for me, doctor. Okay.
So what is your action if it is Kawasaki?
Okay, so if it was a Kawasaki, so the best management to start intravenous immunoglobulin 2 gram per kg before the before 10 days of onset of fever, and then continue add on with aspirin 20 to 30 mg per kg until for 4 to 6 weeks or until 2 to 3 days after the fever subside. And then after settle the acute management, I would like to continue with maintenance medication of the aspirin 2 to 3 gram per kg. Other than that, do a supportive management such as if patient have any dehydration during presentation, I was to start giving fluid maintenance and fluid resuscitation.
So I cannot understand what is the meaning is the best treatment. Is it optional?
I'm sorry, doctor.
You said the best treatment is to give IVIG. Is it optional for you to give or not to give?
Oh no, I will refer to my to my superior and discuss regarding the case first.
No, okay. You discuss with me and we came to the conclusion it is now Kawasaki.
Okay, all right.
So, what will be the treatment?
Based on what I understand, it will be the intravenous immunoglobulin.
Intravenous immunoglobulin. Do you know the schedule for that?
Schedule. I just know regarding the dose that need to be given.
Yes.
2 gram per 2 gram per kg for 4 to 6 weeks or until 2 to 3 days after the fever subside, and then add on with aspirin 20 to 30 gram per kg.
So
Yeah.
for every patient, you will. I may agree that even in emergency department, sometimes you need to give IVIG because it is very protective.
Okay.
But if you, for aspirin, you need to give it whatever the situation, or do you need, or you specifically for carditis?
If there is already involvement in terms there is an involvement of the cardiovascular system, so we need to start the aspirin.
So it is not.
Sorry, doctor, I cannot hear you.
Sorry, doctor, your voice not clear.
Can you hear me?
Yes, not so clear.
Hello?
Your voice seems lagging, doctor. I think maybe it's the connections is not so good.
Very important.
Doctor, I'm sorry, cannot hear you properly, doctor.
Yes, can you hear me now?
Yes.
I think that data is not so good. I don't have Wi-Fi. So please, you must be clear that to say if I suspect Kawasaki, I may need to consider urgent IVIG with considering consultant my senior and discussing the issue of money, because IVIG is a very expensive medication. If it is covered or not, the family must know. And at the same time, after echo, we may need to continue aspirin for how long a time like that, because it is not for every patient. If there is no IV, IG did a good job and we cannot find the aneurysm, the aspirin schedule is different than if there is. Okay, and the follow up. So I am concentrating
Sorry, Doctor, cannot hear you.
Doctor, your voice is
Sorry, Doctor, we still can't hear you.
No, doctor, we cannot hear you.
what
Can we call doctor?
is
Is it better if we try Google Meet? Is it better?
I think the internet connection at Doctor Place is not that good currently, maybe.
Can we call doctor?
Hi, what's up? Kan boleh call, lepas tu letak on speaker ke? Tak boleh. Sekejap tunggu Dr. respon lah, sabar.
Sebutlah boleh je. Ya, Nadi.
Aduh, aku dah biasa jana.
hello?
Doctor. Hello, Doctor.
Okay, can you please tell me what is the definition and the criteria for diagnosing Kawasaki?
Okay, first of all, need to have a fever, at least 5 days duration, and also have the presence of bilateral non-purulent conjunctivitis. And then there is also presence of rash, characteristically polymorphous exanthum. And then there is also presence of edema or extremities involvement, also presence of a cervical lymphadenopathy, prominently unilateral, and then there is also some mucosal involvement, such as strawberry tongue, erythema at the sole or dorsal area of the hand. That's my answer.
What is the mechanism of Kawasaki?
The mechanism, it primarily due to the inflammation of the blood vessel due to vasculitis, which commonly will affect the medium type of vessels, medium type of artery.
Okay. Can we go ahead for the, please, for the OSCE?
Yes.
Yes, Doctor.
Okay.
So can you see my slide?
Yes.
Yes.
Okay, so for the question first question, who wants to answer? You have to describe the finding and also give differential diagnosis.
Can I volunteer?
Yeah.
Okay. For this one, the finding, there is a strawberry tongue. So the differential diagnosis, the first one, it can be Kawasaki disease. And the second one, it can be scarlet fever.
That's all?
I can't think of anything else right now.
Okay, so the answer is there is a prominent vertebrae and a erythematous tongue, which is characteristic of strawberry tongue. So the differential for strawberry tongue will be Kawasaki disease and also scarlet fever, like Fahana said. And also other causes can be toxic short syndrome and also vitamin B12 deficiency. Okay. For question number 2, who wants to answer? Anyone who wants to volunteer?
I try. So there is presence of neck swelling. Probably there is a neck swelling at the left side. So probably lymphadenopathy, lymph node swelling, and then for differential diagnosis can be the Kawasaki disease also can have the lymph node, and also maybe TB lymphadenitis or lymphoma maybe.
Okay, so basically the finding is there is unilateral swelling at the left cervical region with no other skin lesion. So the differential can be infection such as bacteria caused by TB, virus, and also parasites such as toxoplasma. And other causes can be Kawasaki disease, malignancy such as leukemia and lymphoma, and also inflammatory disease such as lipodystrophy. So question number 3. Patient was presented with fever and rash. So you have to describe the skin lesion, most likely diagnosis, causative organism, and also diagnostic investigation. So who wants to volunteer? Anyone? Um, Aiman, can you volunteer?
Yes. First question, describe condition. So there appears to be a widespread, extensive purplish lesion, discoloration of the skin. I think it's the lower limb, it's the leg.
Diagnosis?
Diagnosis.
Okay. So
I can think.
basically there is a peppery rash of the both lower limb, and if you press it will be non-branching. So usually this kind of peppery rash is caused by meningococcemia, and the organism will be Neisseria meningifida, and the investigation will be culture and sensitivity either blood CNS or CSF CNS or synovial fluid CNS. Okay. So for question number 4, patient presented with fever and rash, and describe the finding, most likely diagnosis, and also prevention. Anyone who wants to volunteer? Atika ada suara? Atika?
Sorry, mic problem. So for the finding, I think there's presence of maculopapular rash over the trunk, and then for the palate, I think is it complete spot at the
Yes,
palate, and then there is presence of is it conjunctivitis?
yes,
So most likely diagnosis is measles.
yes. Question number 2?
So for prevention, vaccination.
Yes, true. So all your answers are true. So basically there is a macular rash that will progress to totally cover the pattern and complete spot, which is the pathognomonic for measles and also conjunctivitis and also Stimson line. So basically the Stimson, can you see my cursor? This is the Stimson line, which is the inflammation along the eyelid margin. This one. Can you see?
Yes.
Okay. So the diagnosis will be measles or other than is rubella, and you can prevent with a vaccination is given at 9 months old and also 12 months old. Okay. Question number 5. Patient presented with fever, sore throat, and also rash. Describe the finding, most likely diagnosis, and also investigation. So who wants to volunteer?
I try.
Okay.
So the limbs, so we can appreciate there is a rash that appear very gritty. I think that is characteristic of sandpaper rash. And then the tonsils are exudate. There is exudative tonsils, injected tonsils, which also correlate with the diagnosis of scarlet fever lah ni. And then pipi dia, the cheeks is flush and erythematous. So most like diagnosis is scarlet fever. So investigation, because commonly this due to the strep infection, so we can do the ASOT for scarlet.
So finding, as Dahiyah said, there is a sandpaper rash and also pustule lines. So this is the pustule lines here. Basically, it is because of the capillary fragility and fracture. And this picture shows the circumoral pallor and also red edematous exudative tonsils. So the most likely diagnosis will be scarlet fever. Investigation, we can do throat culture, extract anti-diarrhea benefit, SBC, and also UPIN. Why UPIN? Because scarlet fever can progress to glomerulonephritis. So you have to check the UPIN. So for question number 6, patient presented with unresolved fever and rash. Describe the finding and how do you diagnose the disease? Anyone who wants to volunteer? Azfar? Azfar?
So patient presented with unresolved fever and rash. So the findings, so we can see multiple rash at the back of the patients, and then there's a swelling on the neck of the patient, and also redness of the tongue, and also we can see the what do you call that? Apa nama saya? Tak ingat.
Discommission.
The finger.
Discrimination.
Discrimination. So what is your provisional diagnosis? Discrimination. It is Kawasaki disease lah basically. So there is a macular papular rash with swollen lymph node and also swelling, redness and peeling of the skin around the fingers, fingernails and also toenails, and also the mucosal involvement, which is cracked fluid and also strawberry tongue. So how to diagnose with the disease, as mentioned by Nadia earlier, it is fever for at least 5 days and also cream for out of 5 days. Okay. So the second last question number 7. This is the lab result for urinalysis for the patient. So we have to interpret the finding and also explain this finding in relation to the case. So for this one, I will call Dahiyah to answer the question.
Okay, so for this question, basically, we can say there is a positive leukocytes in the urinalysis. However, there was no signs of any bacteria or nitrites negative. So instead of Kawasaki disease, which is we call it as a sterile pyuria. Um, Hello.
Yes, we can hear you.
Okay. So what does it mean by sterile pyuria is when there is a leukocyte, but there was no evidence of bacteria or bacteriuria in the urine. So that's all.
Okay. So basically, there is a presence of leukocyte without bacteria. So in Kawasaki disease, this is a typical finding, which is sterile pyuria. So as you can see, the microscopy shows 50 leukocytes. So it is more than 10, so it is called as increase in leukocyte lah. Okay. So last question. A boy, aged 5 years and 7 months, had typical Kawasaki disease diagnosed when aged 1 year and 8 months. The selective coronary angiography was done to describe the findings and also state the complication. Hanami, can you answer this question?
Okay, so this is the angiography showing the angiography of the heart, showing there is a aneurysm of the coronary artery. Okay, and then the complication, what we worry about in the coronary artery aneurysm, patient would develop, so when there is a rupture of the aneurysm itself, so there will be ischemia to that part of the heart region, so patient can develop apa ni, cardiogenic shock because the heart cannot pump more due to the die of the myocyte. So the complication can also be myocarditis. Okay.
Okay. Thank you, Hanami. So basically, there is a giant aneurysm here, which is cruciform in shape. So basically, in aneurysm, in Kawasaki, it can be circular aneurysm or cruciform shaped aneurysm. Circular is for cruciform is for subacute atau composite vasculitis, and at the right coronary artery, and also there is dilatation of the left circumflex artery. So basically, this is a coronary artery aneurysm, and the complication for this aneurysm is just like what Hanani said. Okay, I think that's all for the OSCE.
Okay, thank you. Here, good selection of a case. Please don't forget that fever also one of the most common symptom which the patient will present it to you. especially if it has rashes beside it. Of course, of fever alone, it is very broad. So don't forget, for fever, the most common endemic diseases, which is
Dengue,
what else?
lepto,
Lepto. What else?
COVID-19.
COVID-19. What else?
Malaria.
Okay. Malaria in some area. Okay. Chikungunya can be present. Myelidosis, typhoid can be present. Okay, so don't forget some endemic diseases which can be presented. But if fever with rash, it will be restricted to some diseases which must be forgotten. Of course, dengue, you must know the rashes of dengue and how it looks like and how can be differential diagnosis. Okay, the rashes of leptospirosis and the other documented symptoms. As I told you before, history will guide you for about 75%, examination by about 20, and investigation about 5. So you must go deep about the history. It will guide you if this patient has infection or has other diseases, like patient with autoimmune disease like juvenile rheumatoid arthritis or chronic arthritis of the children. Okay, it will be presented by, in many cases, it will be presented with fever before the rash. Okay, and sometimes it will be presented by rash also. So juvenile chronic arthritis is very important to be considered. Even leukemia can be presented. So fever is not only infection. I need you to consider about that. Fever, yes, maybe infection, and we'll speak about the endemic diseases. We are speaking about even from tonsillitis, speaking about the scarlet fever. We are going to discuss also some autoimmune diseases like Kawasaki, like juvenile chronic arthritis, some autoimmune diseases. All this can be presented by fever and rash. Okay, so it is very important to make our mind now oriented. Many malignancies are presented only by fever and maybe with some rashes. Many autoimmune disease like SLE or other can be presented also by fever with some rashes. Okay, this is number 2. Don't forget it, please. And your job, which I feel that you need to polish it, it is the same. If you meet someone, you need to say why he is it blah or blah? Which person is it? I have discriminating features. For every disease, if you are going to diagnose Kawasaki, so you must be the one who asked the patient, did he got any edema? He has got any peeling of the skin? What about his BCG scar? What about his eyes? Is it red? Is there any secretions or not? This is very important. And you must be the one who initiate and thinking for that, please. Okay? It is not enough the patient will give me, because sometimes the patient will not speak and you will be the one who must speak everything. So if you come to conclusion, you must complete it. And you must say, I am doing a full blood count to search for thrombocytosis, which is very important in this situation. I am going to check, it may be CRB and the SR is high, okay, like this. So it is very important to know, especially if the disease is disease of exclusion, okay. So please try to make your job completed. Fever is one of the most common presentation to our clinic, and we must be very clear. It may be that patient has staphylococcal scald skin syndrome. It may be this patient has the other differential diagnosis, because staph can cause many types of fever and skin rash. It may be the patient have some of the endemic, some of the infectious disease like measles, which you are trying to go to zero measles. So it is very important to ask about vaccination and go and check for the mouse. And every disease, as I told you before, has a specific clinical presentation and a specific lab result, which you mustn't underestimate. You must mention it clearly. This patient presented by cough with tight chest and blah, 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 and I can hear wheezes, and when I auscultated, there is decreased air entry, and there is rhonchi, okay, and the prolonged expiratory, and when I did the spirometer, there is improvement, so it is asthma. So always try to collect the positive and specific points and try to put it in your final summary. Okay. I hope, because the internet is not good at all, you picked the message today. Okay. What is our job in the near future is to be conclusive, is try to define. Now we are trying to translate from the theory to practical. We are trying to transfer from generalization to a specific one. Hoping you will be in the best situation. Hoping the next time when I contact you, the internet will be better than that. Do you have any question?
Doctor, I have a question.
Yes.
Okay, for in IMP, sometimes they ask us how to counsel the patient's parents, for example, like the case of epilepsy, where they want to choose alternative treatment compared to the hospital treatment. So how actually can we consult the parents?
Yes. Thank you for this important question. This is another part of our job as a doctor. We are not only a doctor which must examine the patient and write the medication. We are the one who must counsel the family for many situations, for teaching them important knowledge about the disease. Sometimes we need to counsel the family because they are very upset from something, they are late. So sometimes Mr. Angry, sometimes Mr. You will find a lot of people, everyone on his nature, and you need to deal with all and try to not clash with them. I will just write an example. For any counseling, you must introduce yourself. You must prepare for that counsel in a separate room. No need to carry your mobile at that time, and give them appointment and introduce yourself. And it is better to be another staff with you, either staff nurse or one of your colleague, either senior or junior one, and introduce yourself, and you tell the family, I would like to discuss with you the case of that disease, epilepsy, and its treatment today. Okay. And then you will ask first the patient, what do you know about the treatment? He may know everything you are going to speak, so no need to speak all. Okay. If he said the same message which you are going, so you just said, I mean, and we came to the conclusion. Okay, but if he doesn't, so you must ask him what he knows, and you can start from that point, okay, and building up, or just revise rapidly and put the other point. This is known disease as epilepsy, which is have repeated convulsion without triggering cause. Usually it is due to blah, 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 blah. And our treatment may be continue for long time, 2 years or more, until we settle by the EEG that there is response. We have many options for treatment. It is the same if someone got like tonsillitis or any infection. There is a lot of antibiotic which can work at the time. The medication which your son or your baby is on is not available in the market or is not available in the hospital, and we may need to change to another time, another type of medication. It is the same efficacy and its side effect no difference from the previous one, like that. So you must speak to the family by number one, clear, okay, honest, sympathize. Again, clear, honest, and sympathize. Sometimes the patient is come very angry and they need to complain for something wrong happen to him from either you or from other stuff. You don't have any other option. Please sit down, sir. Please let me listen to you again. Yes, you are correct. This is wrong, which mustn't be done, and we must go through the formal investigation for that. It is not only your right, it is the right of the hospital, it is the right of Ministry of Health to make sure that even if something wrong happen, we are going to get a lesson from that. We need to be improved. Yes, I know that you are the one who included at the time, but we need to prevent it to be happen with other patients. So this is the issue. And so sorry for you. And we will start to investigate. And you're right. And from my point, I'm going to start to tell you sorry. I am so sorry. If I were you also, I will not be happy. But you must consider the situation and how we are dealing with this wrong thing to not to be recurred again. So you must be honest, clear, and you must be social worker. Besides, you are a doctor. You must be able to deal with different people. The one who is hurry, the one who has a problem, financial problem, the one who has no whatever. Everything will come to you. And if you are not good enough, it will make a problem and load over you. Okay? I hope with time we can give you session about counseling. It is very important, really. I hope we find the chance to discuss it in a wide scale, inshallah, soon. Am I clear?
Yeah.
And at the end, you must make summary. So you introduce, I am going to speak with you about that. What do you know? The knowledge which I give to you, either confirmation or addition some knowledge. And the conclusion you repeat again at the end. And then you must write it in the file to be documented. If one of your colleagues come to discuss again, he knows that you speak about that with the mother and father. Okay?
Okay. Thank you.
Okay.
Okay. I think we can come to the end now of our meeting. Let us say سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك ونتوب إليك. بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. Please don't forget Arafah is on Thursday. Hoping if you are fasting, it will be a good favor from Allah.
Thank you, Doctor. Doctor, when are you
Salam alaikum.
coming back?
It may be end of September, inshallah. But I may be around for some time to see you, inshallah. Okay? Thank you.
Okay. Thank you, Doctor.
Thank you, Doctor.
You are welcome. Assalamu alaikum warahmatullah. And
Thank you,
sorry again for
Doctor.
this bad online.
Okay, Doctor.
Okay, Doctor.